Jeremy, how are you? Good. Let me start with the disclaimer. So your scan is here. It's been presumably, allegedly uploaded, but we can't see it, so we're re-uploading it. Hopefully, so I am seeing you without actually seeing the scan, which I've heard anecdotally shows some progression. Okay. Yeah. All right. Well, I'm sorry to hear that. You're feeling fine. You're feeling good. Yeah, Sam told me that you really bolted out of your chair and ran out to see the Blue Angels. And so by definition, that's a normal exam. So we will count on that. And there have been no seizures. So when you say substantial, you've seen the scan? And was it twice the size it was 2 months ago? Well, by eye, it was clear to you that it was different. Okay, fine. So obviously now we're back into a different, we decided that if it grew in the 2 months that we would treat. That's fine. And like standard is to do it sequential radiation followed by Timidor. Is that what they're planning? Which will be fine because that'll, probably, it certainly would give you a bigger bang for the buck than going on the IDH mutant, which we don't know whether it'll work or not. Well, I have no. Okay, so I'll go over the treatment plan, but this is going to confuse you because there's evidence that sequential radiation followed by chemotherapy is the way you should go with this, and so that it's not great evidence, but enough that it kind of forms our thinking. You can also find reports, not quite, always everything has flaws, but you can certainly find reports that suggest that Timidor alone could be just as effective. Um, um, and you can also find reports that, radiation, it's not clear how much radiation is helpful. So you can always make a case for your client, as it were, that if there was something, if a patient wanted to start with Timidor alone, I could certainly work with them. But I think if you really look for a consensus and you're in a big conference room and you got a lot of experts, I think everyone would say now that you do it, with the focus, with the radiation followed by the Timidor. That's what everybody would say. So getting more opinions isn't going to help. I mean, there's always going to be some divergence, and nobody could really support another approach to someone who is as um, detail oriented as you are and data driven. No one would be able to provide a better plan based on available data. Everything else is kind of preference. So I think, yes, I think you're doing the right thing. I have many patients, before and after, um, this particular study that framed the radiation and the chemotherapy, who, when we heard anaplastic astrocytoma, um, and had a complete resection, and we showed that the tumor came back, we treated them like glioblastoma because that's how we used to treat anaplastic astrocytomas, with radiation and Timidor. And those patients really survive a long time. Really, and they're young just like you. They do very well, um, and don't really seem to have pushback from the radiation. We're talking a decade. That's a short time for you, but it's a pretty long time for these studies, and patients do well. So I'm good. I'm good with that. Um, so um, have you heard any different opinion to that yet? All right. So it's a consensus. It's as close as you're gonna get. I want to see, maybe if you give me a couple more minutes, I want to see if they can locate the scan and see if I could look at it. You know, I could share my screen with you occasionally, but you can't, I don't think you can share with me, but you want to try? No, I don't, I promise I'm going to look at it and I will give you, I'll give you a confirmatory, my health message that I looked at it and I'm sure I'm going to agree. I mean, if you saw it, then I'm going to see it, right? So where are you going to be treated? Close to home, I hope? So it's a rule at Stanford that you get tested before, if you're going to be in the cancer center, all patients are tested coming in. So yeah, you would be tested at Stanford. I'm sure at your radiation facility, they will test also. It's not about you, actually, Jeremy. It's about the radiation therapists do not want to treat someone with active COVID either. So it's actually it's at Stanford, it's mandatory that anybody coming in for treatment to protect the other patients as well as obviously the patient themselves that they're tested. Well, I can't speak for the hospitals down there, so I don't know. I mean, obviously they're ramping up testing. And you could ask them about it. You could ask them how they're monitoring it. They generally, I mean, Santa Barbara isn't the third world. I mean, it should be. I'm sure they have. I'm sure. Is that right? No, it's a good issue. It's important. I mean, you're not symptomatic. And actually, I didn't know, so I know Southern California is having a little greater problem than we are up here. So, what's it like in Santa Barbara? Are there a lot of cases? Are the hospitals? No, it would not be so good. You would probably not want, the radiation therapist would not want you in their facility if you tested positive. Not so much that you couldn't tolerate it because you're clearly asymptomatic, and it's extremely unlikely, but if that happened, you would not be, um, um, we would delay, which in your case is fine. I mean, even if we delayed a month or two, it's not a problem, but we would not, with someone who has active COVID, would not do it. Correct. the behavior of these good risk IDH neoplasms are, they stay local, they might grow, so it's in a growing stage, but they're very sensitive, and you've lost nothing by waiting 2 months. And if it's cure is in the wings, cure is, that, and everything suggests by the markers that, when we say cure, we mean, prolonged eradication. We, think that it's likely. Pretty neutral on that. I don't know really what that would add. I mean, it's not going to change your treatment. You're not going to focus on those areas. It's not going to change you to try surgery. I mean, I think, it'll only add to your worry. So, I mean, sure. Obviously, they like the dopa pet. We don't even really do the dopa pets up at Stanford for whatever, logistically or what have you. I mean, they do feel like that's a much better way to show proliferation, but I mean, obviously it's proliferating. I mean, I don't know what you're going to gain. But I guess what I would ask him is, how does that change your management? Either, either in planning treatment or moving forward. Because it wouldn't, I don't see how it would change my management now. That the only way, if it was completely negative, would he not treat? Would he recommend a different treatment? Then I would do it. But if it's not going to change treatment, I don't. Information is great, but you know, you really want to know what you're going to do with the information. And if he doesn't really have a plan, I mean, I know they like that scan. They do it a lot down at UCLA, and they probably feel it helps them. Helps them guide treatment a little bit, and it also adds into their big database, which might have a little. Um, there's a little incentive, to do these cases. So there may be a, personal incentive to do these kind of cases. So in that case, you can ask if it's any research benefit to him, and then it's your call. It's very low. It's as a test, it's very low risk. I don't think I mean, it wouldn't change anything at Stanford. I would be neutral. He hit all the high spots. Basically, um, taking, yeah, yeah, I thought it was very comprehensive, and there were a lot of recommendations, but none of them really have been validated. They're all things that circulate in various ways, shapes, and forms. They all have proponents. I certainly do not see, um, I don't see enough of an added benefit that I would tell you that you needed to take that route. Could you hold for a second? I'm getting a call. I just want to, hello? Good. I'm on the line with a patient. Um, who are you calling about? Who are you? Oh, good. Okay, I'll call you right back. Okay, thanks. By the way. Okay. Yes. So he wrote. Well, in a sense, remember here, this is not because you have a rapidly fatal condition in which we can do nothing about. This is because you have a good risk condition that we think we can control with conventional treatments. Of course, we don't recommend you start smoking or taking any high risk behaviors now, but any lifestyle change, which essentially a lot of these recommendations were, is up to you. I mean, I'm not sure how we would even see if it has a benefit for you. This kind of this is not cancer prevention now. This is kind of preventing recurrence, and that's a really tricky field. I don't think there's anything that is totally validated other than what you plan on doing. Okay, very good. So how should we leave this? Okay. Generally, when you finish radiation a month after that, you get generally at Stanford, you'd get an MRI, we'd see where we were, and then we would start the Timidar. And I generally, during the first year, generally do scans at 2 to 3 month intervals. That depends both on your schedule, my schedule, how much your insurance will let us do the scans. We generally don't follow with, we don't do more sophisticated scanning other than the MRI, which is pretty sophisticated. We don't have any other ancillary tests. The risks of the Timidar are obviously the myelosuppression, the blood counts. We'll have to follow that. Um, most of it is just maintenance. I would say the vast majority of patients tolerate this really well and don't really have a problem. And I would suspect you'd be the same. Once you finish treatment, usually they'll give 6 months of Timidar, but we're flexible. You can do I generally will give up to 12 depending on the patient and their superstitions, and they feel well, they want to continue it, and it's perfectly safe. But more is not necessarily proven to be better. So and probably less might be as good, but 6 cycles is probably enough, um, and then it's kind of a waiting game. We don't, I don't think actually at that stage. One second, I might have gotten your MRI. Let me see, because I'm waiting for this. Hello? Okay. Well, you're remote. So I will try to, yeah, I'm on the line with Jeremy right now, and we're talking. And I told him that I will look at the MRI. I mean, he's seen it. I mean, even he saw the difference. So I'm assuming that it's going to be pretty apparent, and I'll just email him. I'll just my health him the results, and that has to be, and I'll just make sure he gets the communication. Okay, thanks. All right, bye-bye. One of the problems with working remotely, Jeremy, is that I can't, if I'm sure if I was in the clinic, this would have been done already. It's not that I carry that much weight, but I carry enough weight, but there's nobody that, three-quarters of us are sheltered, so we have a very limited um, bandwidth in the cancer center itself. And so I apologize, but we will get this done. I will look at the MRI. Okay, I wouldn't either. I mean, you saw it, and so that's the most important thing. And I trust I know that obviously I'm not going to see anything different. And yeah, from what you described, it's not yeah, we're all on board on this. So I mean, so to finish it off, I guess I was saying that, um, it should be, the thing with the Timidar is the counts, and we'll be following them, and that might result in delays, but it also might, in my experience, some patients really get hammered with the counts, and I sometimes stop early because of that. And about the other thing, this INH drug, I don't think I would. I think I would hold it in reserve until I knew that the treatment wasn't working. Now, so if you want to ask where I could help, the place where I could help is at that MRI after radiation before you begin Timidar, because that's when you sometimes can make mid-course corrections. And then, any other MRI visit after that. But if the MRI looks good and everything, I can stand by. I mean, I'm following the case with interest. Okay. Yes, I think current. Look at it this way. Let's say we did it at the beginning, when you were so hesitant to say, and, basically, it remained under control. And then 2 years later, you wound up with a very large inflammatory, the pseudo progression from the treatment, which can sometimes help. You would be very unhappy, and you would be questioning whether you did the right thing. So now we really have no questions, and because it really has no deleterious outcome in the long term, there's no remorse. If you wind up with this inflammatory process, we'll say, well, we know what happens, we can treat it, it's okay. But that's kind of, that's the price of going for to eradicate it. If it was already eradicated, and a problem happened, you'd feel that would maybe give you remorse. It's still true. It is a stealthy beast. It's interesting that the brain, which is wired so that it could pick up all of these sensitive um, issues throughout your body, is not wired so that you could pick up much in itself. And the reason for that is it helps with the mapping. If you actually were able, it would be very confusing in nature, if the brain sensed itself too much, it has to be dampened down, or else you're not gonna, you're always going to be running in the wrong direction, and you're not going to have a very good survival. So that's kind of why we don't really sense a lot. It's that's why the brain doesn't really sense pain well, and the brain itself is the map for the rest of the body. Well, I would like to reassure you that it's going to be fine. Okay. The what? Stay tuned. I know you've been very good at keeping me apprised, and I promise I will send you a My Health message when I review the scan. Okay. Very good. Good luck. Talk to you soon. Right. Bye-bye.